Thanks, Dr. Amar. First of all, let me thank you for inviting me to be a part of this prestigious course. And it's a privilege to be in this course. And very good morning, everyone. So, before I actually start off, I thought I'll pass on two important informations. Tomorrow we have the, even more exciting event, which is the OPL, the Ophthalmic Premier League, which is being held for the second time in the AIOS. And last time we had a very full house. And it's going to be tomorrow at about 11 o'clock in Hall A, which is the main auditorium. It's a big auditorium, and that's going to be a very exciting challenge where 4 teams will compete for the best video awards. And right after this, in the Hall C, we have another interesting course where Aiki Ahmed is going to present his keynote address on his capsular tension segments. That's my course in the next hall at 11:30. That's Hall C. So with that, I'll just start off. And I wanted to share a few of these difficult situations with the rings and hooks. Now, this was a routine patient where I did a hydrodissection, and you can see that the fluid wave went, and I typically rotate it with my hydrodissection cannula only. Now, this patient had some loose zonules, and as you can see that when I tried to rotate the nucleus, it would not rotate as it would normally do. So I decided to go in with a chopper and try to see if I can rotate it. And as you can see, even though we had a very nice fluid wave, it's not ready to rotate as easily as it should. And then I realized that there may be a bit of dehiscence there, and this video is actually an old one when I was using iris hooks for anchoring onto the capsular rhexis. As you can see, I'm finding it very tough to actually anchor onto the edge of the rhexis because the direction of my hook is not correct. My tunnel is too long. So if you notice here, I'll just take you back a little bit. If you'll notice here, my tunnel here is too long, because of which I'm not able to tilt my iris hook down. So one lesson is that if you're going to put in iris hooks or whatever to support the rhexis, and it's a big subluxation, you should have a smaller, shorter tunnel in the cornea at the periphery. The paracentesis should not be a very long one. Now, once you have this in place, I managed to hook this rhexis somehow. Then I put the second one. This is much easier because now the lens is lifted up. Initially it was tilted down, and now I'm going to start the surgery, and I'm now just assessing. This is after I've made my first trench and I realize that something is not right. Now, if you'll notice, while this hook is still anchoring onto the rhexis edge, this one seems to have come off, and I'll probably have to now go and check whether this one is still there. So I'm trying to rotate it, and now I'm just checking. Just see, with the manipulator, I'm seeing the rhexis is no longer anchored. What's happened is that the rhexis is broken. Now, this usually happens with the iris hooks if you have a lot of rotation or handling of the nucleus, because these are latched onto the rhexis edge. So if you break the rhexis, then you've had it, because now you have a broken rhexis, you have a lens which is subluxated, and you don't know what to do. Now, desperate measures. So I'm trying to see if I can still go ahead with my crack and somehow try to minimize the size of this and try to prolapse it out, make it into 2 pieces, and then somehow bring it out of the bag. I do manage to get 1/2, but as I've got away so many times before, this time probably I'm not going to get away. Some vitreous starts presenting from the 6 o'clock position where there was a subluxation. I somehow managed to get some of this out without touching the vitreous, and you can see that while I'm still working on it, I managed to rotate the second half of the lens outside. I'll just run you through this video. I'll cue it for you. So as you can see, now I'm struggling. I have a broken rhexis, I have a broken bag, I have zonular dehiscence at 6 o'clock, and then all these situations, I'm now trying to use a cutter to actually get out the remaining halves, do a small limited vitrectomy in that area as well to get the vitreous out. I still have half of a nucleus, which I'm now, since it's free of the vitreous, I'm going to rotate it out and bring it and prolapse it into the anterior chamber. Now this, at least I'm not going to have to deal with the nucleus in the vitreous next day. I have this into the anterior chamber, and now I just increase the size of my section, use a sheets glide, and somehow manage to get this out. Now, I was able to complete this surgery, but then this was about 7 or 8 years back when I was not using capsular hooks. So that brings me to my next video. I'm using these MST hooks, and there are several hooks available. As you'll see that this design is different. It anchors on, this part is much longer, so this part never anchors on to the capsular rhexis edge. So your rhexis will never break. What will happen is that this part is actually going to the equator of the capsular bag, and it will support the equator of the capsular bag rather than latching onto the rhexis edge. So you'll see it here now. This was another patient which was noticed to have a subluxation on the slit lamp, but we didn't realize that there would be vitreous as well. So when we started this patient on a peribulbar block, we noticed that there was vitreous which got stained with trypan blue. So sometimes if you don't have triamcinolone, you can actually stain the vitreous even with trypan blue, as you can see here. But we did a triamcinolone staining, and with that we were able to then clear off the vitreous completely. As you can see over there, it's a smaller pupil. I'm freeing the synechiae, Then I go ahead and complete my rhexis. Now once the rhexis is done, you can see that I'm trying to get my capsular hook in. The problem is that we have a small pupil to deal with, and we have a small rhexis, and we have a subluxated lens which is tilting down. So it's going to be a bit of a challenge. As you can see here that I do manage to get my capsular hook in place, and then I am looking for the rhexis edge. The problem was that this thing is not yet latching on to the rhexis edge. I'm always catching the iris. I'm not able to catch the capsular hook. So what I do is then I change the clock hour position. I go to the 6 o'clock position with my capsular hook, and now I'm able to engage the rhexis edge so that now my lens is again going to be lifted up. So you can always do this. You can try to lift up the lens with the manipulator or with the capsular hook. So you can see here now these two capsular hooks are working in a dual mechanism, and you can now proceed with the surgery. I have one iris hook here to keep the iris out of the place, and two capsular hooks which are also anchoring my subluxated lens. You can go ahead and complete the surgery. As you can see now, it's a bit of a small pupil, but we can manage. Now you'll notice here I'm putting a CTR, but you can also see that there's a 10-0 suture which is tagged onto the eyelet of the CTR. Now this is always a great thing to do. Whenever you are not sure about the integrity of your capsular bag, or if you're not sure about how it's going to go towards the end, you can just tie the small 10-0 suture to one of the eyelets and let it be. You can complete the surgery. At the end of surgery, all you have to do is snip it off. Now, in a situation where you had a capsular bag rupture or a PC rupture or a broken rhexis, and if this ring were to dislocate into the vitreous, this suture is all that you need to just pull it and get this ring out. Now, if your surgery goes uneventful and you can get the lens in and everything is done, you can then snip off this 10-0 suture very easily, as you'll see how I'm going to do it now. So I'll just pull on the suture a little bit. My lens is in place, and all I'm going to do is remove the stuff, all the hooks and the rings, and now I'm going to just snip this suture there. Once I snip it, it's gone, and this it works very well to ensure that your ring will never dislocate into the vitreous if you happen to break your rhexis or get a PC rent. So this was how we could complete this case, and went off well. Now this was another, like Dr. Amar always has these amazing videos, and I thought I'll share one of my terrorizing cases. This was a small pupil. Again, this is a video which is almost 4 or 5 years old, but it always reminds me that Malugin's ring is an amazing device, and Boris is a great friend, and I use a lot of the Boris ring, the Malugin's rings. But you have to be very careful when using these rings. There are certain things which can still go wrong. And in this patient, what happened is that we had already done the rhexis when the pupil came down. So as I was proceeding with the surgery, this was an elderly lady, and she had a floppy kind of iris, and I managed to get I was putting this on the iris edge, on the pupil, but I managed to capture the rhexis as well. So if you have a rhexis in place, you have to be very careful that when you put in the Malugin's ring, you should lift up the iris a little bit when capturing this. So I have again released it and put it back. So you have to be cautious, otherwise you'll break the rhexis, you'll pull the lens to one side, and you have to be very careful. So ideal situation is to put the Malugin's ring before making the rhexis. Once you've made the rhexis, it may be a better idea to actually use the iris hooks rather than go with the Malugin's ring. Depends on situations. Now, I was able to complete the cataract surgery very nicely, as you can see here. And after this, my assistant loaded a lens for me, which was the Zeiss lens we were using at that time. Now, you realize what mistake I made was I was doing a wound-assisted injection. I should have actually enlarged my tunnel a little bit and gone and injected the lens right at the mouth of the rhexis so that this lens would have opened in the back. Now, the problem is that this lens has a bigger optic size than my Malugin's ring, and the lens has opened up above the Malugin's ring. So now I thought it's going to be pretty easy. We manipulate these lenses in through the rhexis so easily. We have small rhexis of 4 mm, and we managed to put in these lenses of 6 millimeters or 6.25 millimeters very easily. Now you realize here that I'm trying my best to actually somehow push this lens through the Malugin's ring dilated pupil and into the bag. I already have one haptic inside the bag. I'm somehow trying to see that, normally it's so easy to manipulate these hydrophilic lenses into the bag, but here I'm struggling. And as you can see that, it's just not ready to go inside because the Malugin's ring is smaller than the size of the optic. And whatever I might try, it's not going to go in. The trick was that I should have actually injected it straight into the bag. Now the problem is that this will not go in. I struggled for almost 10 or 15 minutes, and then I had learnt my lesson, and by the time I learned my lesson, you can see that the Malugin's ring has come off the iris. It is also trying to go behind. So it's a total mess. And my patient is asking me, but Dr. Saab, surgery kab khatam hoegi? It's been 30 minutes I've been operating on this patient. And I'm not ready to give up. But anyway, I mean, this was a lesson learned. I had a zonular dehiscence after this. So we then realized that this is not going to work out after struggling for almost 15 minutes. So now when I operate, and that's the take-home message for all of you, when you're using a Malugins ring, don't put it when you've already made the rexis, or even if you put it, then be careful not to catch the rexis edge. And number two, when you actually want to inject a lens, use a hydrophobic acrylic lens and try to inject it straight into the bag. Don't do wound-assisted injections. Make sure that you don't let the lens open up above the pupil plane. Make sure it opens up behind the Malugins ring. I had to explant the lens, and later on we could complete the surgery with a different lens. My last video for 1 minute, and this was borrowed from one of my close friends who's also from the NHS in UK. He's also going to be speaking in my course next door after this. And just watch this video. He encountered a similar problem with the Malugins ring. He had done a perfect surgery, and Dr. Atul Verma is a very, very prolific surgeon in Wakefield, and he's now trying to dislodge the Malugins ring from the pupil. They also have some very senior 90-year-olds who have very bad IFIS, and he manages to get this off. Now he gets one eyelid off. Now he is going to get the other eyelid off from the iris. And as you can see now, 2 eyelids off and a third one. And now just watch what happens. He's got all 4 eyelids off. He's going to start removing this ring. He's not using the injector which loads on right now, but let's see how he manages it. Now he goes in with the injector, and he tries to load this. Now I got this video because I wanted to show that what can go wrong with the Malugins ring if you are not cautious. It sounds very easy to say that you can use the Malugins ring for every small pupil case, but if you don't know the small little things which can go wrong, you can be in a soup. So he's now going to catch this. Let me just cue it for you a little bit. And as you watch it, he engages the eyelid onto the injector and he starts pulling it in. Now as he pulls it in, this thing suddenly twists. It's not catching on because you have to sometimes it's twisted now. Now as it twisted, just watch what happens. And he's trying to now pull it out somehow, and it looks easy to pull it out, but just see what's happened. It's caught on the iris because that loop of PMMA of polypropylene is flexible because the ring got distorted. Now just see what a mess it's becoming. So from a very straightforward simple surgery, you can end up with a major complication like this where the iris is totally gone. He's trying to release it, but it's nicely caught in that small twirl of polypropylene. So I think the lesson is that when used correctly, and you have to know these small little tips about how, what he did wrong was that when he was loading this into the injector, he didn't bother that the eyelet was not caught properly onto that thing, and that's why the ring just twisted out of shape. And now just see that this iris is left. So with that, I think I'm going to close, and I just wanted to share some of these situations with you and how to avoid them. Dr. Amar, I think you can take over. And before I close, I'll just also pass on one information. We have a very interesting session happening just three halls down. We have a tech skill transfer courses which I'm conducting. It's running all through the day on 3 days. And we have small little things which you can learn there. You can learn how to take pictures with the smartphone through the SLIDCAM camera. You can learn how to do video editing, video capturing. We have NABH accreditation courses. They are all 1 hour courses, and you can go and register on the spot. We also have courses on modular OT designing, keynote presentations, PowerPoint presentations. So lots of things, and you can just come in and register and attend those. That's in the Milan Mela Hall, which is just in front of the registration area. Thanks, Dr. Amar, for this chance.